In this presentation, I will talk about the complete denture step-by-step procedure. When this patient comes to you, you have only two options to treat her and provide her with a replacement for her missing teeth. The first option is the complete dentures. The second option is to put implants in her jaws and then put an overdenture over those implants. Whether it was fixed or removable overdenture, but that is the only second option. In this presentation, I will talk about the first option, which is the complete dentures. The complete dentures are done through the following visits. The visit number 1, in which we will take the history from the patient, dental and medical histories, do an examination to the patient's mouth and need what he needs before doing the complete denture, and then start the procedure of making the complete denture, and that is by the primary impression taking procedure. As we can see here in the right pictures, most of the primary impressions for the edentulous patients are taken using the impression compounds. The primary impressions, or any type of impressions, when you want to do them, you should the first thing, you should stand correctly without no leaning, because leaning is bad for you. You are a dentist and you are susceptible to disc prolapse in the future if you do multiple leaning procedures. The second thing is that the patient's mouth should be at the level of your elbows. The second thing that you should know, which is you should select the proper stock tray, which covers all the anatomical landmarks that you want to be covered and the landmarks that will be covered by the denture. For example, the mandible, you should cover all the residual alveolar ridge, and you should cover also the retromolar pad areas. The maxillary arch, you should cover all the maxillary residual alveolar ridge, and all the maxillary tuberosities also should be covered. If the stock tray does not support you with that, you should add some wax to its borders so that it can reach and cover these areas. After that, you should know how to manipulate the material, the impression material, and that is according to the manufacturer's instructions. Guys, again, I insist that you should always know the manufacturer's instructions regarding any material that you use in your clinic. And if you do this, you will know how to manipulate that material and how you can have the best results you can ever imagine about that material. After that, you should place the impression from the back anteriorly with a slow and steady movements, taking into consideration that the middle part or the handle of the tray must coincide with the labial frenums so that the impression will be positioned correctly. After that, you wait for the impression to set, and then you take it out with one rapid movement to avoid tearing of the impression material. After that, you take it out, disinfect it, and pour it to have the primary castes or the study castes. After that, the lab work here is to draw the landmarks on that cast. You should draw a line that is in the deepest part of the vestibules, which is the blue line, and then you should draw another line which is 2 millimeters medial to that blue line, which is the red line. The other red line borders, you should construct your special tray, because, and we are doing this thing so that we can make the special tray shorter by 2 millimeters from the vestibule, so that we will give enough space for the green stick compound to be placed in that areas of the special tray, and we can take the impression of the peripheral areas, or as we also call it as the border molding procedure. After that, we should do the blocking out procedure. The blocking out procedure is done using the wax to eliminate the undercuts. Guys, don't do the blocking out procedure and then see how your special tray or subsequently your record base will stick to the cast, and you will not be able to take it out from the cast only by one way, which is by fracturing it. Okay, so don't you ever forget to block out the casts, because that will lead to the complete retention of the special tray, or subsequently the record base to the cast, that thing that we don't want ever. After that, we make our special tray, we put the Vaseline on the cast, and then we put the visible light cure acrylic resin, and according to the red line, as we have said before, we carve the acrylic, and the rest of the material we need it as a handle and put it in the machine, light curing machine. Then we will have the special tray. That special tray, in the next visit, we will use it to take the final impression of the patient's mouth. The final impression of the patient's mouth represents the exact copy of the patient's mouth. Okay, and the first thing is we should take the impression, or we should copy the borders of the mouth, and that is by the use of the green stick compound. As you can see here in this picture, we burn a little part of its end, and then we put it in on the borders of the tray, quarter by quarter, not by one time, no, quarter by quarter. And after that, we push it by our fingers, making it like a dam. And after that, we insert it into the hot water, and then we put it inside the patient's mouth and do the border molding procedure. And by that technique, we will record the peripheries of the mouth, or the peripheries of the future denture. This procedure is called as the border molding procedure, and it is done either manually by reflecting the cheeks around it, molding it, or by asking the patient to do some muscle movements that will lead to the natural border molding procedure. After the completion of the border molding procedure, or the impression taking procedures of the borders, we will use a final impression material, and mostly here the material that I really like and use in my clinic is the zinc oxide eugenol. It is very good for taking the final impressions for the edentulous arches. Be careful, it is very sticky. You should put Vaseline around the patient's lips and on your fingers, and then take the impression. As I have said before, no leaning the patient's mouth with your elbows level, and you should know the manufacturer's instructions about the zinc oxide inogenol material. Insert it from backwards anteriorly with slow and steady motion, taking into consideration that the handle coincide with the midline of the face. Then remove it with after setting, remove it with one rapid movement and then check it for no bubbles, no tearing, no anything. Disinfect it and pour it to have the master castes. Before pouring, we should do the beading and waxing procedure. The beading waxes are the waxes that attach the boxing waxes to the uh, final impression. Then we pour the boxed impression step by step to avoid the air to be under the stone and make bubbles. And after setting, which is almost for half an hour to 1 hour, you should trim the cast and make it beautiful to have a high grades from your professor, and also to make the access to the vestibules in the cast, the vestibule areas in the cast accessible, because they are very important in the construction of the subsequent thing, which is the record bases. As you can see here in the lower left two pictures, these pinky things are called as record bases. These bases must be as close as possible to the final denture in their accuracy, and they should cover all the areas that the denture will cover in the future, but they are not as retain are retainable as the final denture, because the final denture is done under pressure and it is heat cured acrylic resin, etc. But in general, this record base must mimic the final denture as much as possible. After the making of these record bases, you should make the bitrims, which are the pinky things that are made from the wax. As we can see here in the lower right pictures, 22 millimeters from the anteriorly, 8 millimeters posteriorly. That is the dimensions for the upper bitrims, 18 millimeters anteriorly, and 2/3 the height of the retromolar pad area posteriorly for the lower bitrims, 6 millimeters width anteriorly, 8 millimeters at the premolar area, and 10 millimeters width at the molar area. So that after taking the primary impressions and making the primary castes and making the special trays and taking the final impressions using those special trays and then pouring them and making the final castes, now we have the exact replica or copy of the patient's mouth on which we will construct and build our complete denture. Because as I have said before in the video of the removable partial denture video, no one dentist has ever until this moment developed a way or a technique to construct the prosthesis inside the patient's mouth. If we can do that, we will not need to copy the patient's mouth anatomy or the patient's mouth relationship records. Anyways, after copying the patient's mouth anatomy in a shape of these master or final castes, then we will take them and take the record bases and the bitrims on them and make the third visit in our construction procedure, which is the jaw relation records visit. Guys, we have, when the patient's mouth is edentulous, we have a space. That space that is gonna be occupied by the new dentures, so that we should record that space. when I am saying a space, so that of course it is a three-dimensional space. And because it is a three-dimensional space, so that it will have a height, a width, and a third dimension. And to record the relationship of the mandible to the base of the skull in the sagittal, in the coronal, and in the horizontal planes, I mean the moving relationships of the mandible to the base of the skull and the maxilla, we use an instrument called as a phasebow. The phasebow will record the rotational jaw relationship of the mandible to the maxilla and the base of the skull. If we can do this, we will have better relationships, we will have less eccentricities or parafunctions and premature contacts. After recording the rotational jaw relationship, then we will record the vertical jaw relationship, and that is by asking the patient to swallow. After swallowing, the patient will have a resting position of his mandible, as I have swallowed right now. After swallowing, the mandible will go into a rest position directly. That rest position minus 2 equals to the vertical occlusal position that we will depend on to build our denture vertical dimension. After the record of the rotational jaw relationships, the vertical jaw relationships, then we will record the horizontal jaw relationships, which are the centric and eccentric jaw relationships. The eccentric jaw relationships are not recorded, but the centric jaw relationships are recorded by asking the patient to touch his uvula with his tongue. The tongue muscles will spontaneously reach through the mandible to the centric jaw relationship, which is the horizontal jaw relationship that we want to have. Okay, so that again, in the visit number 3, we will record the jaw relationships, rotational, vertical, and horizontal. After doing that, we will send the master castes that are mounted on the articulator to let the technician arrange the teeth. Guys, the teeth selection and teeth arrangement procedure are very simple. The teeth selection procedure depends on the material, shade, size, and shape. The materials are acrylic, porcelain, or metal, but the most important one and most widely used one is the acrylic because of its ease of manipulation, because of its aesthetic and function, and it is cost effective. It is cheaper than the metal or porcelain teeth. The shade, we have multiple shades from the yellow and orange to the gray and blue shades, and the shade depends on the sex of the patient. Whiter for the females, age of the patient, darker for the elderly's, complexion of the patient's face, darker faces need darker colors, and of course patient's preference. And the size. The size of the teeth must coincide with the size available in the interarch space. Finally, the shape of the teeth, we have rectangular, oval, or tapered teeth, or a mixture of them, which depends on the patient's face. And finally, for posterior teeth, we have the 0, 20 degree, or 33-degree shapes occlusally. This is the general selection procedure for the teeth: material, shade, size, and shape. Then we arrange the teeth. We arrange the maxillary teeth according to the midline, which will be the mesial uh, surfaces, which will coincide with the mesial surfaces of the maxillary centrals, and that is 1 centimeter anterior to the incisive papillae, 1 centimeter anterior to the incisive papillae, and from the midline we will start our arrangement of the maxillary central incisors, and then we arrange the maxillary lateral incisors 1 to 2 millimeters higher than them, and then our canines with the same level of the maxillary centrals. Then we will arrange our lower anterior teeth 2 millimeters posterior to the upper anterior teeth, and that is to make the appropriate overjet. After that, and overbite, which is 2 millimeter typically. After that, we complete our arrangement of the lower posterior teeth in the triangle between the cusp tips of the canines and the end borders of the retromolar pad areas. In that triangle, we will arrange our lower posterior teeth. After that, we will arrange our upper teeth in a situation where the lingual or palatal cuspes of the upper teeth will coincide or sit in the central grooves of the lower teeth. That was a summary for the teeth selection procedure and teeth arrangement procedure. After that, the denture will be ready for the fourth visit, in which we will try what has been made during the previous visits. In the try-in procedure, we will do 3 things, and only 3 things. The first thing is to check the jaw relations, and the vertical jaw relations are checked by asking the patient to say the S sound. When the patient says S, the upper and lower teeth will have an end-to-end relationship with a feather edge space between them. If that is okay, that means the vertical relationships are okay. And also we should notice the muscle tone and the aesthetics of the lower third of the face. If it is shrunken, that means we have a decreased vertical dimension of occlusion. If it is tensed, that means we have an excessive vertical dimension of occlusion. And also we check the horizontal jaw relationships, and that is by asking the patient to close slowly. And if we noticed that one tooth contacts the opposing tooth before the other teeth, that is called as a premature contact or an eccentric occlusion, which is the thing that we don't want to have. As you can see here in the upper picture, the maxillary right primary molar has a contact to the lower 6 or the lower primary molar before the other teeth, and that is the premature contact, and that is the eccentric contact, or as we call it as eccentric off. And that is the abnormal horizontal jaw relationship that we don't want to have and should correct before the fabrication of the final denture, so that the jaw relationships are measured by the S sound, the vertical jaw relationships, and asking the patient to close slowly to check the horizontal jaw relationships. The second thing to check is the aesthetics and phonetics. The aesthetics are checked for the midline. Most importantly, if there is a midline shift, we should check the high and low lip lines, shade, shape, size, and arrangement of the teeth. And the general thing, if it is live looking or artificial looking. That is your judgment and your experience. These things will play their role here. And the phonics are judged by again asking the patient to say the S sound to check the vertical jaw relationships, and the F sound to check the horizontal uh, or anterior posterior teeth relationships. Guys, as you know, the anterior teeth are the teeth responsible for your most of your phonetics, so that if they are arranged abnormally vertically or horizontally, that will affect your phonetics. So that we will check the vertical teeth arrangement by the S sound and the horizontal teeth arrangement by the F sound, because when the patient says F like 15, the upper teeth will touch the dry wet line, uh, the dry wet line, and if the teeth are arranged more anteriorly, it will touch the dry area, or if they are arranged more posteriorly, it will touch the wet area. So that you should examine the patient by asking him to say F and see if it touches the wet dry line or not, and correct that accordingly, so that you check the aesthetics and the phonetics by again asking him to say the S sounds and the F sounds. After that, we should determine the post dam area by drawing it on the palette using an indelible pencil from the hamular notch area from one side to the hamular notch area to the other side. Guys, do you know what is the hamular notch? The hamular notch is the fossa or notch that is present behind our wisdom teeth, upper wisdom teeth. That area that you can feel it by putting or inserting your finger is the hamular notch. Your post dam area will extend from, as you can see here in the lower right picture, the post dam area should extend from one hamular notch on one side to the hamular notch on the other side, and anterior to the fovea palatini 2 millimeters from it. Okay. Okay. This is if we can determine it anatomically. Also, we can determine it histologically by noticing the difference between the color of the tissues. The hard palate has a different color from the soft palate, which is darker, so that you can know where is the, because the area between the hard palate and soft palate mostly is the post dam area. And finally, we can determine it functionally by asking the patient to say ah. When the patient says ah, there will be a vibration between the soft and hard palate area, which is called as the vibrating line, and that vibrating line should coincide with the post dam area. Anyways, after knowing the post dam area, whether anatomically or histologically or functionally, we should draw it, as we have said before, by an indelible pencil, and then we should insert our record bases. The record bases will have the color of the post dam areas, and then we should take the record bases and put them on the master castes. The color will be transferred to the master castes, and on the master castes we should carve a little groove which is almost 2 millimeters depth or less actually, uh, in which the acrylic will be injected during the fabrication of the denture, and then will act like a dam, so that it will prevent the ingress of saliva or anything else during the using of the denture, retaining it. Okay, that dam in that posterior area, it is called as the posterior dam area or the post dam area determination procedure and making it in the denture. So that was the try-in appointment. We checked the relationships, the aesthetics and phonetics, and finally we did the post dam area. After that, we we send the of course what we have done to the lab. They will do face tuning, which is the final shaping and making of the size of the waxes to mimic the gingiva as much as possible. After that, uh, the technicians will cook the denture. Again, I think it is like cooking because it is mostly a heat cure acrylic resin, and it is put in a boiling water, so that it is like a cooking procedure as Beckham does. It likes, it looks like it is very delicious. Anyways, so that after these steps we have copied, as a summary, we have copied the anatomy of the patient's mouth through the impression taking procedures. Then we have copied the relationship, the spatial relationship between these anatomies through the jaw relation records visit. And then we constructed something that records these things, which is the record bases and the bitrams, and then we have transferred them to the articulator and arranged the teeth on it and tried them in the patient's mouth, and then we cook the denture. This will lead us to the fifth visit, which is the visit of the delivery. We should deliver the patient the denture, and here we do two things. The first thing is to correct the impression surface and borders of the denture if there is any high spots in them by the use of the PIP or the pressure indicating paste, and correct the occlusion of the denture by using the selective grinding procedure. You should, guys, there is no one denture that has no high spots or centric, let's not say centric os, but abnormalities in the occlusion, so that you should do the selective grinding procedure at the delivery date, either through the clinical remounting or inside the patient's mouth. You do the selective grinding procedure. This is the first thing, to correct the impression surface and occlusal surface of the denture. The second thing is to instruct and educate your patient. You should instruct the patient and educate him about the things that will happen during the wearing of this denture. You should tell him that during the after 2 months from now you will get used on it and you will restore your original phonetics and function. After 1 week from now, your excessive salivation will be decreased. After 3 days from now, we will discover if there is any high spots that will lead to sore spots, and they will be removed. And you should also tell him that he should wear it on the day and clean it with the if it is a partial denture with the present teeth. Here there are no teeth, so that he should clean it only, or no, if it is a single denture, okay. If it is a single denture, you should instruct him to clean it and the present teeth, and at the night he should drop it and put it in a water and salt, or a water and sterilizing disc. This was the summary of the delivery day, is two things, and after that you should have a follow-up appointment to see if there is any sore spots or anything like that, and to see what is the resorption process that happens to the residual ridges, the denture condition, etc. That was a summary for the steps to construct a complete denture. I hope it was beneficial for you. Always try to know, always try to spread knowledge and construct the world. Be kind to one another, because life is not short but it is limited, and that is for the greatest benefit to the humankind.